You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 13th, 2022. This week, hypertrophic cardiomyopathy, SGLT2 inhibitors, the triple whammy, espresso, and burnout. First topic, big news came from the FDA this month with their approval of the novel drug mavacamten, which I covered during the April 8th podcast. To briefly review, mavacamten is totally novel and first in its class. It is a reversible inhibitor of cardiac myosin. And of course, that's important in hypertrophic cardiomyopathy as excess myosin-actin crossbridge formation and dysregulation are the cause of hypertrophic cardiomyopathy. Mavacamten shifts the overall myosin population towards an energy-sparing, recruitable, super relaxed state. In short, it is a negative inotrope. The FDA approval was based on the Explorer HCM trial. This was published in The Lancet back in August of 2020. Explorer was a placebo-controlled RCT done in 13 countries, and it enrolled patients who had a gradient of just over 50 millimeters and class 2 or 3 New York Heart Association heart failure. The trial had 251 patients, and of course, patients in the mavacamten arm had dose adjustments to optimize the response. That is a decrease in the LVOT gradient on Valsalva, but maintaining an ejection fraction greater than 50%. The primary endpoint for Explorer was a composite functional endpoint assessed at 30 weeks, and it was defined by objective measures of function and also subjective reductions in New York Heart Association functional class. And indeed, a greater proportion of patients met the primary endpoint at week 30 in the mavacamten group compared to the placebo group. It was 37% versus 17%. And of course, the drug also had greater reductions than those in placebo in post-exercise LVOT gradient and improved symptom scores. Now, that was in 2020. At ACC just a couple months ago in April, the Explorer HCM authors reported a long-term follow-up study called MAVA LTE, long-term extension, which is a dose-blinded extension study in patients who completed that Explorer study. Now, that paper is not yet published, but we were told that improvements in gradients and NT-BNP and New York Heart Association functional class were sustained at a median follow-up of 62 weeks. But there were some safety signals. 11% of patients had temporary treatment interruption for things like QT prolongation, high drug concentrations, and 5% of patients for left ventricular ejection fraction less than 50%. Of course, remember, mavacamten is a negative inotrope. And overall, 77% of patients remained on the treatment over the long term. And recall that that's in a super careful RCT. Remaining on treatment in the real world, where things aren't so controlled, may be even less. Neither the FDA nor the Bristol-Myers Squibb press release mentioned the VALOR HCM trial. This was another study presented at ACC. And this trial also showed positive results for the novel cardiac myosin inhibitor mavacamten. VALOR enrolled patients with hypertrophic cardiomyopathy who were referred to big centers for septal reduction therapy with either surgical myectomy or septal alcohol ablation. These patients had quite severe hypertrophic cardiomyopathy and obstruction. This was a short-term trial, and the primary endpoint was avoidance of septal reduction therapy, and the results strongly favored mavacamten. Only 18% of the mavacamten arm met the primary endpoint versus 77% of patients in the placebo arm. The absolute risk difference was 59 percentage points. In VALOR HCM, mavacamten also performed well in clinical and echo parameters, such as improvement in one or more functional class, resting LVOT gradient, Valsalva LVOT gradient, NT-proBNP, and troponin levels all favored the drug over the placebo. Okay, my comments and details on this FDA approval. Like most new drugs, there's going to be a learning curve. Mavacamten looks especially challenging. I mean, you need to do lots of echoes. You need to carefully read these echoes before and during therapy. Then there are the dose escalations and changes. And you can't start the drug if the ejection fraction is below 55%, and you need to stop it if the EF gets below 50%. That is a very tight window. And there is a black box warning for the possibility of heart failure. And there are significant drug-drug interactions. For instance, use of mavacamten with cytochrome P450 inhibitors or discontinuation of certain cytochrome P450 inducers may increase the risk of heart failure due to high mavacamten levels. Thus, the use of the drug is contraindicated with the following: moderate to strong CYP2C19 inhibitors or moderate to strong CYP3A4 inhibitors. My friends, that is a lot of drugs that will either preclude use of mavacamten or require extra caution in its use. Fortunately, the drug will only be available through a restricted program called the REMS program. That's because of the risk of heart failure due to systolic dysfunction. Now, this REMS program will include, get this, prescribers must be certified by enrolling in this program, but patients must also enroll in the program and comply with ongoing monitoring requirements. And pharmacies must be certified by enrolling in the program and must only dispense the drug to patients who are authorized to receive the drug. And even wholesalers and distributors must only distribute it to certified pharmacies. So that's a lot of restrictions. Now, Maya E. Guglin, professor of clinical medicine and advanced heart failure, physician at IU Indianapolis, said that mavacamten represents, quote, an almost revolutionary change, end quote, for treating obstructive hypertrophic cardiomyopathy. Okay, I think the drug holds promise, but after reading that nearly 25% could not continue it in a seriously rigorous clinical trial, and the details of the prescribing information, and the total lack of clinical outcomes data, I guess I would emphasize the almost modifier for revolutionary change. But it is potential progress, and that is a good thing for these patients. But we must keep alert for safety signals, especially an increase in ventricular arrhythmias. Okay, next topic. Heart failure with preserved ejection fraction news. AstraZeneca, the makers of dapagliflozin, reported via a press release that the top-line results of the DELIVER trial were positive. Recall that DAPA is a sodium glucose cotransporter 2 inhibitor and is already approved for patients with CKD, diabetes, and heart failure with reduced ejection fraction. The DELIVER trial is a phase 3 RCT looking at the use of DAPA in patients with heart failure and preserved ejection fraction. Its primary endpoint was a composite of three things: CV death, hospitalization for heart failure, or an urgent heart failure visit. That's slightly different from the EMPEROR Preserve trial, which was EMPA versus placebo in patients with heart failure with preserved ejection fraction. EMPEROR Preserved used only CV death and heart failure hospitalizations as its primary endpoint. The press release says the positive trial will be presented at a future medical meeting. Some brief comments. I don't like these pre-meeting or pre-paper press releases. I feel like they act as anchoring bias, as in they prime us to already know the drug works, and we start our critical appraisal from the point of view of a positive finding, like a car salesman starting negotiation from a high price. We should not do that. Recall that EMPA in EMPEROR Preserved did not reduce CV death and had only approximately 3% reduction in heart failure hospitalizations, which was statistically significant. But heart failure represented less than 15% of total hospitalizations. Total hospitalizations in these 71-year-old adults with heart failure with preserved ejection fraction was not different in the two groups. And I see this as a classic example of statistically significant but not clinically significant nor high in value. So the question in the analysis of DELIVER is whether we see the same pattern. Heart failure hospitalizations is only an important endpoint if it represents a majority of hospitalizations and or if it reduces total hospitalizations. I really appreciate the discovery of the SGLT2 inhibitor class, and I use these drugs often. But they are costly, and like any costly therapy, we should use them when they have a proven clinically significant benefit. Okay, third topic is the triple whammy. There is a paper published in the journal Mathematical Biosciences, which I have never covered. This study studies the all-too-common triple whammy of renin-angiotensin system inhibitors, diuretics, and nonsteroidal anti-inflammatory drugs and their risk of acute kidney injury. Obviously, this is a huge problem because RAS inhibition and diuretics are used in patients with heart failure and hypertension, and there is a lot of people with these conditions. And well, guess what other common condition often coexists in older patients with these two problems? Yes, pain due to arthritis. And since nonsteroidal drugs are over the counter, many vulnerable patients think, okay, if a pill is over the counter, it is safe. But volume depletion from diuretics plus RAS inhibition plus nonsteroidal anti-inflammatory drugs is indeed a frequent cause of AKI. Now, I'm not going to go into the details of this paper because A, it's too technical, B, it doesn't matter what the mechanisms are. We know this combination is bad. And C, I remember learning about this combination of NSAIDs and RAS inhibition at IU decades ago. Our chief of medicine was then Craig Brader, and he was a pharmacologist, so Indiana University medicine trainees were well schooled in these issues. And a kidney specialist can correct me, but I seem to remember that the combination is bad because it reduces glomerular blood flow, perhaps via nonsteroidal-induced vasoconstriction of the afferent arteriole and RAS-induced vasodilatation of the efferent arteriole. The reason I make note of this well-known combination is that avoiding it is a seriously high-value way to avoid AKI, acute kidney injury. And my views on nonsteroidals have evolved over the years. I used to be strongly opposed to use of these drugs in vulnerable patients, no negotiation. And not only for those patients on RAS inhibitors who are at risk for AKI, but also patients with AFib on oral anticoagulation who are at risk for bleeding. But then someone reminded me that chronic pain and immobility from pain is also a bad outcome. And if nonsteroidals help improve functioning, there may be an acceptable risk trade-off. So my new approach is to use acetaminophen first and second, and refer to ortho to see if they can help with, say, injections or joint replacement. And then sometimes compromise in some patients and try and get them to take the least amount of NSAIDs possible. Okay, next topic, espresso and total cholesterol. The journal Open Heart published a nutritional epidemiology observational study on different types of coffee and their association with total cholesterol levels. Let me make 3 quick points. First, we have enough coffee, blueberry, chocolate, raspberry, etc. studies, and I've written about this before and will link to that column. Look, the world has a lot of health problems we need to get solved. These sorts of studies do not move the needle. Due to the huge amounts of confounding, plus recall bias of food questionnaires, studies like this that look at one macronutrient with observational methods is simply not going to advance our knowledge base. It's just not worth the effort, in my opinion, and sorry to the authors in advance, I mean no malice. Okay, second comment. I'm going to link to a very beautiful paper from 2013 in which 2 authors identified 50 common ingredients from random recipes in a cookbook, and then reported that they could find studies that showed each of these ingredients could be associated with an increase or decrease in cancer risk. My friends, macronutrient research is fraught. Third comment, it doesn't matter what health outcome espresso is associated with. I love it too much to give it up, especially before a big bike ride. Okay, final topic today is clinician stress. Medscape News has nice coverage of a very topical discussion at the American Telemedicine Association annual meeting. First, who knew there was such a congress? Okay, the discussion centered broadly on clinician, nurse, and doctor burnout, which is a growing and costly problem in the U.S. More specifically, the panelists addressed one of the main contributors of burnout, which is our many bureaucratic tasks. One of the panelists, Dr. Peter Yellowlees, professor of psychiatry and he's chief wellness officer at the University of California, Davis, discussed his efforts to address burnout before it occurs. And one of his tricks, one that caught my eye because I have embraced it full on, is the clinical notes. In training back at IU, I prided myself on these exhaustive notes. But the moment I joined private practice, observing master clinicians changed that point of view. Many of my older partners would go into a room and in seconds come up with the right therapy. They would then go to the paper chart and write assessment, CHF, plan, diuretics and blood pressure control, period, next patient. This taught me quickly that I was foolish to think good medicine is about writing long notes. Well, Professor Yellowlees, now decades in the future, is working on retraining physicians who for many years have been trained to be defensive in their documentation, to write absurd amounts just to justify billing. He noted that studies have found that American notes were 3 to 5 times longer than the notes of the Australian or UK physicians. And he said that he's worked in all 3 of these countries and testifies that there's no difference in the quality of the doctors across these places. I could not agree more with his philosophy. I have learned to type very short notes that have the key phrases that their coders need. I almost never cut and paste. I have a very rudimentary template, and I write 1 or 2 things about the person that when I read it in the future, I will remember. Quote, Mr. Smith is a retired math professor who toiled for years helping 7th graders at school X, Y, or Z. You would be shocked how much you can get into a short note. I've passed my coding inquisitions every time I am tested. And coders don't care about quantity. They just need to read the right content. For example, these phrases. Here's an example. Quote, the new onset, moderate intensity, near daily palpitations occurred in the left chest, lasting minutes, and were brought on by coffee and relieved by deep breathing. Boom, there is your content. Now, no one would ever write or talk like that, but it works pragmatically. I am not advocating for not putting important material in the note. Yes, of course, put all the important stuff in. But learning how to write short allows you to spend more time with the patient and your family. And no one cares about grammar and form in a medical note. Writing short, though, is like a procedure. It takes effort and practice. And I do this drill a lot. You write a passage of, say, 400 or 500 words. Then practice writing the same thing in 200 words. It's one of the reasons I like Twitter. You can write out a thought, and it's almost always too long. Then you can work to eliminate unnecessary words. Try this and see what happens. It's amazing. I can't reiterate how valuable it is to minimize your time with the nonsense of medicine so you can focus on helping people, which is what makes this job so great. So that's it for this week in cardiology. As always, I am grateful that you listened. And remember, if you like this podcast, it really helps if you can give it a rating, write us a little review. These sorts of things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.